Hi, my name is Heidi Hazy, and I'm in the DNP program at Palm Beach Atlantic University. This is a presentation on the practice guidelines on the diagnosis and management of syncope published by the European Society of Cardiology. The clinical guidelines that I will discuss are published by the European Society of Cardiology. In addition, one will also be able to understand the diagnosis and management of syncope. They will be knowledgeable of the recommended diagnostic testing and the diagnostic criteria that must be met. Another professional organization that I will touch upon is the American College of Cardiology and their 2017 clinical guidelines for the diagnosis and management of syncope. The clinical guidelines that will be discussed throughout this presentation are recommendations for the diagnosis and management of syncope published by the European Society of Cardiology. While the ESC composed its first guidelines in 2001, it had changes in 2004, 2009, and 2015. The latest clinical guidelines were updated earlier this year in March of 2018. The guidelines were developed with the special contribution of the European Heart Rhythm Association and are endorsed by European Academy of Neurology, European Federation of Autonomic Societies, European Federation of Internal Medicine, European Union Geriatric Medicine Society, and the European Society of Emergency Medicine. The task force that was put together to compose the current clinical guidelines range from cardiologists, which form a minority of the panel, experts in emergency medicine, internal medicine, and physiology, neurology, anatomic diseases, geriatric medicine, and nursing. Their names are Michelle Brignol, Angel Moya, Frederick J. DeLange, Jean-Claude Deharo, Perry M. Elliott, Alessandra Fanciulli, Artur Fedorowski, Raffaello Furlan, Rose Ann Kenny, Alfonso Martin, Vincent Probst, Matthew Reed, Ciara Rice, Richard Sutton, Andrea Ungar, J. Gert Van Dyke, and the ESC Scientific Document Group. What I found to be interesting was while reading through the clinical guidelines, I found where the task force prides themselves on their recommendations being patient-oriented and focused on therapy. And simply, they just want to reduce any further syncopal episodes in patients. They say that they try to provide as much advice possible based on the appropriate therapy from their expertise of the task force. Syncope is defined as a total loss of consciousness related to cerebral hypoperfusion. Syncope is characterized by a rapid onset, short duration, and spontaneous complete recovery. There are two types of total loss of consciousness, which include being related to a trauma or not related to trauma. These current guidelines reflect the total level of consciousness not related to trauma. The TLOC, not related to trauma, can be classified even further into several subcategories: syncope, epileptic seizures, psychogenic transient loss of consciousness, and miscellaneous group of rare causes. There are so many reasons as to why syncope can occur, thus the importance of assessing the patient to determine the cause and be able to treat it appropriately. The purpose of any guideline in medicine is to have a set list of criteria to be able to diagnose someone with a specific disease and take the approved treatments based on best evidence-based practice and utilize it on their patients. The purpose of the clinical guidelines for syncope published by the European Society of Cardiology is to establish what syncope is. So A, diagnosing someone with syncope and determining what the cause is, and then B, to be able to have an option of treatments that have been scientifically proven to work for syncope and assist the clinician with treating the patient based on what has been proven to work. When a patient first presents with syncope, the clinician must first take a detailed history to see if it truly was what we define as syncope. Initially, the following 4 questions must be answered. Was the event TLOC? In case of the TLOC, is it syncopal or non-syncopal origin? In case of suspected syncope, is there a clear etiologic diagnosis? And is there evidence to suggest a high risk of cardiovascular events or death? TLOC is probably syncope when there are signs and symptoms specific for reflex syncope, syncope due to orthostatic hypotension, or cardiac syncope, and signs and symptoms specific for other forms of TLOC, like head trauma, epileptic seizures, psychogenic total loss of consciousness, and/or rare causes are absent. Some signs and symptoms of reflex syncope include syncopal event after experiencing pain or fear, after unpleasant sight, sound, smell, prolonged standing, during meal, being in crowded and/or hot places, with head rotation or pressure on carotid sinus, as in tumors, shaving, or tight collars, and are associated with sweating or nausea or pallor, often experienced before syncopal episodes. If the person has a syncopal event after standing from a laying or sitting position, this could be related to orthostatic hypotension. Cardiac syncope occurs when the person is experiencing some sort of cardiac arrhythmia like bradycardia, heart block, bundle branch block, SVT, or ventricular tachycardia, or pacemaker or ICD dysfunction. Cardiac syncope can also be related to ischemia after a heart attack, or it can also be cardiopulmonary, stemming from conditions such as a pulmonary embolism, aortic stenosis, or an acute aortic dissection. Some of the diagnostic testing that we can perform are listed on the screen above, and I'll explain each in detail now. Physical examination, including supine and standing blood pressure measurements to rule out orthostatic hypotension. An electrocardiogram is needed to rule in an arrhythmia or malfunctioning pacemaker or ICD. An echocardiogram is beneficial when heart disease is known. It can also allow the clinician to visualize any structural heart disease or syncope secondary to a cardiovascular cause. An ECG, to rule out any seizure activity. They can do a head-up tilt testing when there is suspicion of syncope due to orthostatic hypotension or reflex syncope. This test is also known as the tilt table test, and it tilts the patient in a head-up position at different levels, and the blood pressure and heart rate are monitored. It's thought to recreate any syncope related to that orthostatic hypotension or reflex syncope. Blood tests like hemoglobin and hematocrit to rule out any bleeding. An ABG can be performed to rule out any hypoxemia, troponins to rule in any ischemia caused by a heart attack, or a D-dimer when pulmonary embolism is suspected. Initially, the clinician should be asking the following questions after diagnosing someone with syncope. Is there a serious underlying cause that can be identified? What is the risk of a serious outcome? And should the patient be admitted to the hospital? If this is a serious underlying cause, like a potentially fatal heart rhythm, they need to go to the ER and have it further evaluated and treated there. If there is a risk of a serious outcome, the patient should also be admitted and treated in the inpatient setting. Low-risk patients are the ones with the reflex syncope or orthostatic hypotension, so just avoid the cause, avoid the syncopal, and you would avoid the syncopal episode. High risk are the ones with the cardiac issues that could be potentially fatal. They need to be admitted and treated in the inpatient setting. Treatment is also based on the cause of syncopal episodes. If the patient has reflex syncope, they need to be educated to avoid any triggers that might cause their episode. People with orthostatic hypotension should be evaluated to see if there's a cause, like maybe a possible medication like a beta blocker that's causing bradycardia that needs to be evaluated. And be educated on standing up slowly. Don't go from a laying to standing position. Sit at the edge of the surface first and then stand slowly. Patients with arrhythmias should be treated accordingly depending on the type and cause. Bradycardia may be caused by a beta blocker. Remove the beta blocker. Patients with a heart block should have a pacemaker placed. Patients with a malfunctioning pacemaker or ICD should have that corrected. Patients with PE should be hospitalized, maybe placed on a heparin drip, and have an intervention in the IR lab. Maybe they need the TPA infusion with the ECOS machine to relieve the PE. Patients with aortic stenosis need to be evaluated for the severity. They may need surgery, and aortic dissections are always immediate surgery. The main difference between the older versions and the new guidelines is that the current guidelines for 2018 incorporate supplementary data. This allows an expansion of the content to practical issues and to help fill the gaps between the new evidence and actually getting it into the practice. The supplementary data includes videos, flowcharts, and checklists that are easily accessible online to be at the clinician's fingertips when needing to know how to diagnose and manage patients with syncope. While there are no major differences between the European Society of Cardiology 2018 clinical guidelines and the American College of Cardiology 2017 clinical guidelines, the wording of the guidelines were slightly different. The most important similarity of the two guidelines shared was the importance of obtained and detailed and accurate history and physical. This is because there are a number of things that can cause syncope, and this must be evaluated. In addition, someone might think they have syncope when in fact they do not meet the inclusion criteria mentioned in the diagnostic criteria slide. They may have another illness that needs to be evaluated. The one thing that the American College of Cardiology mentioned was to obtain an initial EKG after the H&P is performed to immediately either rule in or rule out cardiac etiology, as those can be fatal, versus the reflex syncope. And another thing that the American College of Cardiology mentioned is that routine and comprehensive blood work is not useful in the evaluation of syncope. However, the European Society of Cardiology mentions that you need the blood work to rule out or in certain diseases such as bleeding with an H&H, hypoxemia with an ABG, troponins to rule in any ischemia caused by a heart attack, or a D-dimer to rule in a pulmonary embolism. So the wording is kind of different. The American College of Cardiology, they just want the EKG initially after the H&P, and they may or may not use any blood work with their diagnosing. However, the European Society, they definitely want the EKG, but it didn't specify exactly when, unlike the American College of Cardiology, and they said that you would want to use that blood work to either rule in or rule out certain causes. In conclusion, the European Society of Cardiology has set forth clinical guidelines for the diagnosis and management of syncope based on best evidence-based practice and the expertise of the task force. They recently updated their clinical guidelines in March of this year. They identified certain diagnostic criteria for diagnosing syncope, the recommended diagnostic testing for syncope, and their management recommendations. The American College of Cardiology has also published their own clinical guidelines, last updated in 2017, and they follow along the same lines as the European Society of Cardiology, with minor differences in the way theirs is worded. I thank you for listening to my presentation on the diagnosis and management of syncope based on the 2018 clinical guidelines published by the European Society of Cardiology.